Hello, everyone, and welcome to our Hope for HS webinar. My name is Melanie Brown, and I'm one of the many Hope for HS volunteers working towards raising awareness for HS. We're a volunteer, grassroots, patient and caregiver-directed nonprofit advocating for HS patients since 2013. We have several ways to keep in touch. We have a public Facebook group, Twitter, Instagram, and website presences open to everyone. We also have a private Facebook support group for patients and their caregivers. Today, we have Dr. Syed from UNC Dermatology, and he will share information about individualized treatment plans for HS. I'm pleased to turn the stage over to him now. Welcome, and we're glad you're here today.
Great. Yeah, thanks so much for having me. I always love to come and spend time doing Hope for HS events. It'd be great when we can eventually get back to in person, but doing the virtual stuff's great. I think it helps us reach an audience we couldn't usually reach. And so I'm glad to talk some today about individualized treatment plans. And what I mean by that is, sort of focusing on, how everybody's got very different disease in a lot of ways, and sort of either the degree of inflammation that's present, how progressive it is, how severe it is. And so there's not a one size fits all approach. And so I think being able to think through, different scenarios, how to approach things in those instances can be very helpful for sort of figuring out, what, each individual patient's, best plan is. So I'll give some relatively common scenarios. It is definitely even, it's not, 5 or 6 size fits all. So just even the scenarios I walk through won't fit everybody, but I think it'll give us some general background of sort of how I think things through when I'm trying to treat a patient, and just to give an idea of what different options might be out there and what things might feel like a good fit. I'm going to go ahead and get my screen share going. And I'll give a shout out, Hope for HS. I think hopefully a lot of you are familiar and have been on the website. I've got my Hope for HS t-shirt on today from the walk that we did recently, or the walk, run, rest. So I just wanted to give a quick call out to that for those who haven't had a chance to participate in that. I'm sure Angela and Melanie can give a little more background on that too at the end. I always like interaction. And so if anybody has questions they want to ask, you're welcome to put them into the chat box. You're welcome just to sort of jump in, and I'll try to keep my eye out for any questions that come up and try to sort of do it in the moment when it's relevant. That, or feel free to wait towards the end, and we'll just kind of use them to add to the discussion at the end. And so let me again share my screen here. And I think everybody should be able to see. I'm going to go into presentation mode. There we go. And so I think everybody can see it. If not, somebody please stop me before too long. But again, I gave some background here. And so, I think there are certainly times where at the beginning, it can feel very tough to know what to do, and it can feel overwhelming in a lot of ways, especially because, it's a very common story that patients have been dealing with this for years and years, and have had, lots of different sort of, piecemeal attempts at trying to do better with things, or maybe just had no idea what was going on with it. It didn't have a diagnosis for it. And so the beginning kind of feels like there's, a lot of uncertainty around it, and it can certainly feel scary kind of thinking through, what does this mean when I have to develop a treatment plan? Is there going to be, procedures, or are there going to be medications that are involved that I'm worried about taking? And it can be hard, and especially starting off when I was first starting to see more and more patients with hidradenitis and having to think about this more and more. It was a little bit scary for me too, trying to think through what's the best way for me to do this and try to reliably get help for people. And so I think over time that becomes more clear, but I recognize from the patient standpoint, the path is unique. As much as I've seen it many times, it is something that, patients haven't had to see and view over time, and don't have a great understanding as to what steps may come next. I would say most of the time, even though HS can be very frustrating sometimes, and that there's not, one thing that gets everybody better, most of the time we get a lot of improvement. It's hard to get it perfect sometimes, but most of the time we can make big strides in the right direction. Medications can be part of that. Medications are nice in that they sometimes can calm inflammation down quickly. So if there is issues with a lot of pain and just being able to sort of do daily tasks, medications can often help, sort of set things back on track to some extent and make quality of life better. There can sometimes be limits to them, as we'll talk about as we go on further. And because there's often scarring and tunneling that is, somewhat unique to HS compared to other skin conditions, there are sometimes, those are the areas that are most stubborn, that either take the longest to sort of really improve as much as they can with medications, or that eventually we start thinking about procedures over time. And so depending on where the starting point is, that's kind of how we have to build a treatment plan around, sort of what, where the starting line is. And so kind of moving along, this is the treatment guideline. So this is what was published a couple of years ago that sort of outlined a general approach to care. And this is, I think, very confusing to look at to start with here. The main sense, I don't expect anybody in the audience to sort of, go through every last detail of this, but the main point I'm trying to make is that it's not a one-size-fits-all approach, right? So you may have heard of Hurley staging before, where Hurley stage 1 is considered, and this isn't a perfect correlate for mild, moderate, and severe, but mild means there's just bumps that come and go. Hurley stage 2 means there started to be some scarring and maybe some of the tunneling lesions that are more stubborn. And Hurley stage 3 is where there's very extensive scars and tunneling. And as you can see here, many of these treatments that we talk about using, so a lot of the antibiotics are sort of clustered here in the middle. Some of the things like lifestyle modifications, hormonal treatments, or the biologics, those are things like Humira or adalimumab. These kind of get used across the spectrum of disease severity, depending on individual cases, because some patients, even with early stage 1 disease, if they're getting, a lot of new bumps sort of over and over again, and it has a huge impact on quality of life, we might use some of these things we consider more aggressive or further down the line in terms of treatment algorithm. And it's not just one thing at a time a lot of times. So it's not saying here that we have to use, clindamycin or rifampin first, and then use Humira after that, and then use these other things. We often have to combine and use these things together. And so I can tell you from a clinician standpoint, it's confusing for a lot of clinicians to sort of think through, which of these things to use at which time point and how to combine them in a way that sort of gets the best outcome. And so I think from a patient standpoint, especially too, it's confusing to know, to have any idea which of these things are the things that you would want to start with also. And so that's where it's our job as clinicians to provide some education around different options and try to find the things that are the best fit. And try to make sense out of this so that it's more than just, a list of things that could be used in any scenario. When I start thinking about treating a patient, the first thing that I'm trying to achieve is going to be stabilization and getting quality of life better. That doesn't mean that I have to get 100% clearance over the course of, a few weeks. That's a hard goal to try to meet. But what I do want is that, if there's trouble with either, attending school, making it to your job, spending quality time with your kids, how can I make it so that there is less pain, less drainage, things that will sort of let people get back to living a more normal life where the HS doesn't have as much of a daily impact. And also that things aren't progressing. That's a big, tough thing to assess in HS. Are things, stable? That doesn't mean they're good, right? There can still be lesions that are sort of flaring constantly and causing trouble every day. But is there spread of new lesions, right? Is there development of new scars and not just the old scars and tunnels that are continuing to act up? And so trying to figure out how can we stabilize and keep it from getting worse, which can often be the case, is that if we watch a whole lot of patients over the course of a couple of years or 5 years, at least some of those patients are going to get worse as time goes on, meaning spread in new locations and sort of worsening of the scarring and tunneling. And I want to stop that progression first and foremost, and then hopefully reverse again those quality of life impacts that are occurring. Long term, that's where we have to sort of change strategies a lot of times. It means that if things aren't ideal after a first pass or a second pass of medications, how do we, sort of, change things to do better? Or sometimes with medications, maybe we hit a wall with how good things are getting. And we think through where maybe surgical procedures play a role too. And so usually it's not jumping straight into sort of big surgical procedures and throwing every medicine in the world right away. It is, doing things that are thought to be most likely to help sort of calm things down, stabilize them. And then once things are stable, how do we again troubleshoot and sort of get past where things seem like they plateau if there's been a limit to the improvement with what we're doing so far. Take a quick pick at the chat box. So when it comes to antiseptic washes, what should we look for? So that's a good question and something that's probably like a little more specific, than, but we'll pause and kind of think about that. So with antiseptic washes, there is not, one particular one that I could point you to that is like the best for everybody. A lot of, I think Hibiclins or chlorhexidine washes get used a whole lot over the counter. That's what, like, if you're going to have a surgical procedure done, a surgeon will often have you sort of wash with that the night before because it's known that it reduces, how much bacteria is present on the skin. Some people will just use things like Dial antibacterial soap, or there's been talk around like selenium sulfide containing shampoos that are also kind of antibacterial and antifungal. Nobody's ever really done comparison to show that these things are like, one is clearly better than the other. And there's things like benzoyl peroxide, topical clindamycin, which is a prescription. So I can't say that one is definitely better than the other. Things like hibiclins can be a little irritating sometimes and have some alcohol. So you want to kind of dilute them and sort of use them like on a washcloth or loofah, as opposed to just kind of applying them straight to the skin most of the time. And so, again, I think part of it is a little bit of trial and error, and sort of, and there are some common things that are out there, but we can wrap back around to that too. The other question is, can hidradenitis be on the face or scalp? And certainly, people have what looks like hidradenitis in the scalp. We often call it dissecting cellulitis of the scalp, which is probably, when it comes down to it, just HS that affects the scalp. And there are certainly people who get it along the beard area also. Those are relatively uncommon places. I would say probably less than 5% of the time, and probably less than 2% of the time even, but they can certainly occur. And I think, lumping that into, and often it's in the context of hidradenitis in other places, so it probably is just an extension of disease. All right, I'm going to keep on moving through the presentation here, but like I said, I'll keep an eye on the chat or other questions. Let's see. So I mentioned kind of stability versus progression. How can you tell that things are stable, and how can you tell that they are actively progressing, getting worse? When do you need to act to change things based on that? And so, a telltale sign is that if there are new lesions that are still coming, meaning it's not just an old area of scar or tunnel where the same spot has flared up, 2 times, 5 times, 10 times, and I think often patients have a very good idea about where those areas are. If it's on, what was completely normal skin that hadn't flared up before, and you develop a new nodule, a new abscess, where the tunnels are spreading, that is, in my mind, indication of progression, right? New lesions occurring, and not just the old areas continuing to act up. Recurrent lesions, again, I mentioned those old scars or old tunnels where just an abscess continues to rebuild or it chronically drains all the time. That's a sign of sort of a disease that's been there for a long time. If that's all that is present, that is relatively stable disease. And of course, there are times where both happens, where there's the old recurrent lesions, but on top of that, new lesions are still developing. And so, if there are new lesions continuing to come up over time, that means my medication is probably not doing what it should do, especially if that's happening very frequently. It can be hard, again, to get to absolute zero. And if it's, 1 or 2 very small, bumps that come up every year that go away very quickly, that's, relative stability. It's not perfect, but that's a big improvement sometimes from where things started. But if there are still a lot of new lesions happening, spread of tunneling, that means that action needs to be taken to adjust to that. If all that's present are the old stubborn recurrent areas, again, that's where there's a limit to medication sometimes, and we start thinking about surgical procedures to address those most stubborn areas. And so that's kind of, how I sort of break it down in my mind. Some of, the things that are chronic and recurrent that have been there for a long time, I can usually improve them with medication. That's where I get some hint, even early on, that surgery might be part of getting somebody the best they can be down the line. And so even at a first visit where I know there's a mix of new and old things, I'm going to talk through, medications, something to try to put the fire out, but kind of planting the seeds of, maybe it's not time for surgery yet, especially if somebody's very hesitant, but, 6 months, or 3 or 6 months down the line, if there's, these couple of areas that look like they're old tunnels, that may be where we run into a wall, and it's going to feel like adding that down the line to get you the best you can be. And it just helps to lay that out, to kind of help, I think, people think through the future and sort of what their treatment path is going to look like, as opposed to it feeling like a real unknown. And so, again, telling what's old and what's new, and if it has flared more than 2 or 3 times in the same spot, it is probably going to flare up again. And I think a lot of patients know better than I do when I first take a glance, exactly where those areas are. I've gotten pretty good over time at sort of having a good sense of where that stuff is likely to be, just based on having seen it for a lot of patients and been through procedures and getting a sense of where it stops and starts. But I think a lot of patients, especially when it comes to even, before a surgical procedure, pointing out those areas that, hey, maybe this is quiet today. Sure, it doesn't look too bad, but it has flared 5 times, and I can tell it's still there and is likely to flare again. And so pointing those things out can be pretty helpful, actually. And then, again, but then there are things that have only been present for a short time. When a brand new abscess comes up on skin that was very normal to start with, that abscess is certainly going to be painful for a week or 2, and it can be useful to do things to address it. But you jumping in, right away with a big surgery for a lesion that's likely to resolve and heal on its own is probably not the ideal situation. A surgery doesn't necessarily help that heal faster. Again, but once there's been that up and down, long, where an area has clearly been recurrent and seems like it's going to keep on coming, that's the time to think about where surgery fits into the picture. And so another question here. So often medications prescribed for HS patients have side effects. And often for me, the side effects are just as bad or worse than the HS. So how do you deal with that as a doctor? Is the goal to mostly clear the HS or to up quality of life in totality? So, that's, a great point, and sort of like segues into this slide actually. So, one really important thing for me, and I think doesn't get stressed enough sometimes is having shared input on the decision making, right? And so I think the point you're getting at is, sure, maybe medications can be somewhat helpful for the HS, but what is the price of getting things better, right? What are the drawbacks to the treatments we might choose to use? When it comes to surgery, if patients have a lot of hesitation around surgery, I don't twist somebody's arm to do that. I kind of lay out, these are the ways in which it'll be helpful. This is what the recovery is going to look like, and this is kind of what the trade-off would be. And if you say, look, I'm good enough without surgery, I would never talk you into it. And the same is true for medicines, right? I think understandably, having that fear of putting something, foreign into your body and sort of knowing there can be a long list of side effects, that is intimidating. And for some people, is more intimidating the idea of a surgical procedure. And so really, I spend a fair bit of time trying to feel out, what somebody feels comfortable with and what they don't feel comfortable with. And again, I don't know that is always given enough credit on the provider side. But I spend a lot of time talking through, there are a few different treatment options we could think about. these are potential side effects of it. This is how likely I feel each is to give you benefit and how much benefit you might get from them. And then I have a patient kind of help me choose and sort of weigh those risks and benefits together. And sometimes it's a stepwise approach where we escalate over time and try to make sure we fit the patient best. Some patients say, I'm never taking a medicine. And for them, maybe we focus on surgery, and the trade-off with that is that, if all you do is sort of repeatedly cut things out, sometimes that means more new things are going to pop up because you're not stabilizing the background disease. But if a patient says, look, I'd rather deal with surgical procedures over time than be stuck on medicines all the time, then I would certainly, work with that and just do the best I could to work within those limits. And so yeah, I think it's always a discussion of, side effects and trying to, feel out, again, what things feel like they're tolerable risks and what aren't, and then coming to a decision together on that. And then, kind of another question here that I'll do. I know all patients are different, but at what rate would new lesions keep spreading? They start in the common areas and if left untreated or undertreated, but they continue spreading to areas where they wouldn't normally appear in the beginning, like starting in the groin and going further down the leg. So that's, a really hard thing to predict. And there have been a few studies that have tried to figure out, what is like the natural course of HS. Like if you don't treat it at all, what is it typically going to do for most patients? And of course, that varies a huge amount. And that's one of the things that's toughest to predict. Because a patient can have, very, very, stable disease for a long time. And then for whatever reason, something makes a few new spots come up over time. Generally, if somebody says, I've had disease for, 5 or 6 years, it's had, a relatively stable course where I get a few lesions here and there. I don't expect that to take off overnight and sort of explode out of nowhere. There are some patients where, within the first 6 months to a year, it has just already spread to multiple locations and has become very severe very, very quickly. And for those patients, I know that their trajectory is probably not going to be good over that next year, where it's going to probably worsen even more. And so you can get some sense based on, the timeline of what's happened so far and how quickly things have spread. But it's tough to predict. On average, if you look at patients, there was a big study that was done looking at patients over a 4-year period where there wasn't any changes done to medication other than just whatever the doctor seeing them were doing anyway. And I can't remember the exact percentage now, but there was, a significant number of patients where over the course of 2 to 4 years, they developed some lesions in new areas, or they developed, they went from Hurley stage 1 or 2 in certain areas up to Hurley stage 2 or 3. So, and some of that has to do with things like age probably too, sort of in that, teens to sort of 20s timeframe is when disease probably tends to be most likely to pop up in new areas over time. And maybe a little less so as time goes on, but that's not a sort of a hard and fast rule either. And so I feel like that's a pretty subpar answer because I feel like I don't have subpar information to work from. So I wish I kind of had better answers there, but The main thing is, over the course of, the last 3 to 6 months, that's kind of what I'm paying the most attention to is, how much, is it spreading over that time frame? Because that tells me it's kind of in the next 6 months, probably pretty likely to either continue to spread, or if it's been stable for a good while, probably relatively likely to stay somewhat stable at that point. But over the course of many years, it's hard to predict what the ups and downs necessarily be. And so then ask a little bit about laser. I have a couple slides, or a slide that kind of mentions that later. So I'll wrap back around to that question. Then at age 33, one patient saying they got worse, and that can absolutely be the case. Whereas the average typical age of onset is like teens and 20s, and it's sort of most active. Then there are certainly some patients that get worse later on in their 30s or 40s. I've got some patients in there, like very, very few, but in their 70s or 80s that worsened around that time. It's very, very odd. But it's not, again, where it always follows like that textbook course. And the same holds true for a lot of conditions like, rheumatoid arthritis or Crohn's disease tend to have peaks around age like 20 and 40. And that's probably the case with HS also. But then there are scattered, age kind of all throughout different ages, scattered ranges where it can kind of pop up also. So I wish it was perfectly predictable, but it is something that, can be unpredictable and that we just have to adapt to some extent. All right, I'm going to jump back into the presentation here. And so then the question of, what to expect as far as from treatment. And this is an important point early on in discussions of sort of what are we going to get out of this, right? If we're going to commit to a medication, what sort of changes would I expect to see, and what are the limits of the improvement I might expect with each of those treatments? And so medications in general, I want those to reduce inflammation, right? So that means that if people are getting a lot of new lesions, I'm hopefully slowing that tide and making it so fewer new lesions pop up. And so those old stubborn recurrent areas are less painful, less red, they have less drainage present. For some, there are times where, we can treat things kind of on and off to some extent if the flares are relatively intermittent, but there are times where those medication commitments end up being longer term because, HS in and of itself is something that happens over the course of many years sometimes. And so I can't, at least at this point, it's hard to say that I would fix it with just 6 months of a medication. And so that's one of the frustrating things is that it's not a quick on and off of medication most of the time. It is something where we got to figure out what feels like a good fit over potentially a longer period of time if we need it to work that long. And the limits of the medications are fixing, scars and tunnels, right? Reducing inflammation with a medication, gets rid of, again, the redness, the pus, the drainage. What it does not fix, though, are things like scar, at least for the most part, right? Or if a physical tunnel or pocket is developed under the skin, sometimes if you calm the inflammation down long enough, those areas can heal. But a lot of times there's been a physical change to the skin. And that's why HS, is harder to treat than things like psoriasis. With psoriasis, I give a patient a medicine that's a chronic rash that comes up and I can fix the rash or get very, very good control of the rash. That's also a long-term commitment to control it over time because that's something that also comes and goes over time, just like rheumatoid arthritis or things like that. But because HS sort of remodels and changes the skin, that's why things are so much more stubborn sometimes. That as much as I can cool it off, as soon as you sort of, take the brakes off and you sort of take the medication away that's suppressing things hopefully well, it can kind of just explode right back from those areas that couldn't sort of be totally remodeled back to normal again. And so that's where, again, that's the limit of medication sometimes is sort of fixing those most stubborn areas. Sometimes medications do so well that, there's no pain, there's no drainage. And somebody says, I don't care if there's some scarring and tunneling left behind because I feel good. And that's where I feel good too. But often if there's very extensive tunneling, those areas are more likely to be recalcitrant and maybe more likely to need procedures over time. And if it's just a few areas like that, it's maybe small focal procedures. If it is, widespread and sort of a lot of tunneling, that means bigger procedures and sort of more procedures sometimes. And so in the beginning, it's a little, there's some possibility of sort of predicting, what those following months or those next couple of years look like and what it's going to take to sort of get things, again, the best they can be. And so I was going to run to a couple scenarios here, again, that sort of illustrate the approach. I'm going to pause and take a quick look at questions here. Is Humira the only medication besides antibiotics that's being used for treatment? Is it the only FDA approved? So yeah, it is the only FDA approved treatment. That doesn't mean it's the only treatment. And I, use other things just as much as Humira for sure. But even all the antibiotics that people get all the time aren't technically approved for HS. And those were approved a long time ago for bacterial infections. And HS is not an infection. It's a chronic inflammatory condition. Humira is approved because that company did big studies that kind of, created, good quality evidence saying that if you compare patients on the medicine versus not on the medicine, some of those patients get better. Doesn't mean all patients, and definitely Humira can be frustrating and not good enough for a lot of people. There are some where it's great, but there are a lot of other things we use that are not approved. And I'll go into that some more in a later slide. And then another question for postmenopausal women with obvious hormonal flares over the last 30 plus years and no long-term relief with surgery antibiotics. Is a full hysterectomy a possible treatment? And so, hysterectomy, the uterus is responsible for some hormones that are produced, but most of it comes from the ovaries. So getting rid of the uterus by itself usually does not have a huge impact on things. I can't say that that's like 100% across the board, but not usually as much of an impact as perhaps, and again, I would not say that having the ovaries also removed, that sort of gets rid of where most of those cycling hormones come from. I would not say that's like a typical treatment to consider doing, just because it'd be unpredictable. Like I can't say that always fixes things, especially if they're old tunneled areas, and that even without that hormonal trigger, being there, maybe are still going to act up to some extent, but it's possible. It's possible that could lead to improvement. And we use things sometimes like spironolactone or finasteride, things that are sort of hormonal blockers to try to lessen that impact. But those things are certainly not reliably helpful. And so, to have ovaries removed, that essentially is going to induce menopause. There are some, long-term issues that go along with that. And so that's why I'm hesitant to get too strongly behind that. But I'd say that, theoretically, you take away those hormonal triggers, that can be helpful. The other thing we sometimes do are things like birth control, just to stop menstrual cycles, where you do continuous active birth control. And that can sometimes help, not always either, but sometimes that will help get around those premenstrual flares if you can kind of, suppress cycles successfully that way. And I would probably try something like that first, a way of sort of suppressing cycles medically rather than going through surgery and having ovaries sort of irreversibly removed. But again, that's something where, it's hard to know the right answer on that. The other question is about scrotal skin and what could be done to fix that. So again, biggest thing is, reducing inflammation first typically and trying to make sure things are stable. Surgery can certainly help, fix with those kind of things. Sometimes if it's, focal areas on the scrotum that are involved, small procedures are helpful. There are reconstructive urologists that sometimes do bigger, sometimes plastic surgeons too that do bigger procedures. Sometimes all of the scrotal skin is removed, or for women that have extensive involvement of the labia or the pubic area where there's been extensive swelling throughout that area that just, if there's chronic edema, meaning sort of chronic swelling of the area, and sometimes you reduce the inflammation and that goes down, but some of it can stick around. And that is where sometimes it takes a bigger surgical procedure. And so that's a bigger commitment when it comes to healing, discomfort. I don't take that lightly. But sometimes removing like all of the scrotal skin or all of the involved areas, it's a big procedure, but it can have big benefits. But that is definitely something that's worth discussing and thinking through and making sure you sort of understand the healing process before jumping straight into something like that. But a lot of patients feel like, obviously it's not fun to go through that procedure, but it was worth it afterwards. It was, it's not perfect afterwards, but much, much better than where it started from. And so, if, previous surgeries have been sort of suboptimal, it'd be a matter of, figuring out, hopefully from, clinicians with expertise, getting pointed in the right direction with who can kind of maybe handle things in a more complete way. And then I'm going to do one more question, and then I'll get back to the slides and kind of come back to the questions in a little bit. So what's the best way to deal with all the double-ended pseudocomedones or blackheads? Is there a way to safely remove them? So, some patients get a lot of blackheads, some don't get any at all, but a lot of times because the follicles have sort of dilated or scarred in some way, there can be little tiny blackheads that get kind of left behind. And sometimes there's a little bit of scar, and underneath that scar, 2 or 3 blackheads, or more than that sometimes, will sort of pop out along the edges. So we call those multicomedones, or double-ended comedones if there's 2 of them. And what basically happens is there's little dead skin cells that get trapped underneath that bit of scar or within that dilated follicle. And as they build up, they sort of form this sort of plug of whitish material. When that's exposed to oxygen, it turns black from oxidizing. And so the tip of it looks like a blackhead, but behind it, it's usually more of a whitish color like any other blackhead. And so those are frustrating because you can try to remove them. You can use what's called a comedone extractor in some cases, which is like a little thin instrument about this long. If you look up comedone extractor on Amazon, you'll find a bunch for probably $10 or less. And it just is like a little metal rod with a loop, and you kind of push down firmly and sort of push the loop across there, and it will often sort of help pop the little blackhead out. Sometimes if they're multi-comedones, it's hard to really do that. And I think some patients use like a little tiny instrument of some kind to sort of push through kind of one side and sort of push it out the other. You just have to be very careful doing that not to traumatize the skin. And the trouble is, within a week or two, those areas tend to come back and they tend to kind of refill back up. So it is like a maintenance thing, and it's annoying because you have to keep up with it. In some cases like that, when they're very bothersome, I'll do tiny procedures where I sort of numb up around it and I remove that little bit of intervening skin that sort of entraps where those comedones fill. Or if it's a single comedone, you can use what's called like a little punch biopsy tool to sort of remove the entire blackhead and follicle around it. But again, that means some scarring left behind. That doesn't always feel like the best trade. And sometimes people do things like Retin-A or sort of other sort of topical retinoids, and sometimes that helps a little bit, but it is frustrating sometimes. And so I think I've got a good idea of where I'm stopping on the chat right now, but so I'm going to come back. I see the next question here, but I'm going to pause for a second and do some slides, and I'll do a group of questions in a moment. All right, let's see. Gotta minimize some screens here. Okay. So this is like an early scenario where there are bumps coming and going. You can tell there's like a little bit of discoloration from past bumps here. Kind of here, one that recently healed, but kind of smaller pustules, some tender nodules that are popping up here. And so this is where things haven't had a chance to progress much through sort of that scarring and tunneling. And so this is a scenario where surgery probably plays a somewhat limited role. To cut out all of the skin when each of these bumps are going to heal, and then maybe new bumps are going to come up around the edge, and that's probably more surgery than is worth doing for a patient like this. There are sometimes times where somebody's just had this for a long time, medications have been suboptimal, and they say, look, I'd rather just go through a big surgery, and that may sort of cut down again how much skin can sort of would potentially be affected. And so sometimes that can feel like the right fit, but most of the time it's going to be worth trying other things first. And so kind of with earlier mild, and I say mild, not to say that it's not a big impact on quality of life. I think even mild HS is sort of a huge challenge, right? Like, if somebody's constantly just got even one or two painful bumps like that, and that changes how they use their arm, it is not easy to put up with that either. And so it's certainly worth doing things about it, based on how much impact it's having. And so typically non-surgical options are more of a focus for these patients. So that's going to be things, again, like trying to find a good fit from an antibiotic standpoint. That's not a good fit for everybody. I mentioned some of those hormonal options, things like oral contraceptives or spironolactone or finasteride that we sometimes use, or things like metformin, which is typically more of a diabetes medicine. But metformin has some impact on things like insulin signaling, which also can be related to inflammation. And so sometimes can also be helpful in a way to sort of avoid antibiotics. Lifestyle changes get mentioned a lot, and I wish I could tell you there were like great studies of which types of lifestyle interventions are helpful. I think a lot of people have personal triggers more than I have the ability to sort of generalize those things to everybody. But whether it's things like, shaving hair closely versus trimming, with a hair trimmer of some kind, sometimes people find that helpful to not cut so close. The things that are sort of the over-the-counter supplements that can be done are things like zinc has had a couple of small studies of low dose zinc maybe being helpful, or things like turmeric supplements. That's more sort of word of mouth and anecdotal, just talking to many patients. And so, maybe those things can be beneficial and are a way to sort of avoid, medications. For a lot of patients, those things just aren't enough, and that's the challenge. And the same is true for diet. We could talk a long time about, different dietary things that people try. We maybe wrap back around that to the end if that's a point of discussion that people want to cross. But I don't want to get too far off track there. But certainly dietary things, if it feels like there's dietary triggers, and avoiding those can be a consideration at a stage like this too. Somebody asked about lasers earlier. And so at a stage like this, hair removal lasers can often be very, very useful. The idea being that inflammation starts around hair follicles, especially for these early bumps. If you destroy and sort of reduce the number of follicles around, that can prevent how many new bumps come up over time. I expect that not to be as helpful for when there's a lot of the scarring and tunneling, like that kind of scar or kind of laser that just removes hair follicles. probably does not have, as much of an impact on scarring and tunneling as I'd like. Sometimes I'm pleasantly surprised with it, but that's where I know that laser has a limit, sort of like some of the medications do. CO2 lasers are different. If you've read about CO2 lasers before, that's a cutting laser. That's essentially the same as just doing surgery to cut areas out. And so that's probably not super useful at this time point either. One big thing to decide in a situation like this too, is this something where we're going to try to do intermittent treatment of some kind or episodic treatment where people say, look, I only flare every 2 or 3 months. For me, antibiotics are pretty helpful. And I feel like, I don't want to be on an antibiotic all the time, but I'd like one when I have a flare because it seems like it calms it down faster. And so for a lot of patients, I make sure they've got, a prescription for antibiotics all the time. They've got some at home. And so then, when they sort of get a sense that something's just starting to flare, they can jump on it sooner rather than later, instead of having to wait to contact me. And then it takes a day or two to get something to the pharmacy and get it picked up, and things have gotten worse in that time. And so just having something on hand is helpful. That or again, whether something continuous is useful, right? So, maybe we do something like hormonal intervention, like contraceptives and spironolactone is a continuous thing if it feels worth it. Save antibiotics for only episodic flare-ups if they're happening, and hopefully they're happening less often with those hormonal treatments. Or again, things like the laser is something we do to start with, and just use antibiotics on and off over time. So it's really a matter of feeling this out over time, seeing how good the control is with these early options, and then again, troubleshooting and escalating if we need to over time. That's very, very different than when patients have more stable and recurrent disease, right? So I kind of mentioned, that first patient, has, again, not a lot of scarring and tunneling, but they've got a lot of new lesions popping up all the time. And so I'm going to be very worried about them developing tunneling, developing scarring as more time passes. Whereas if a patient says, look, I've had, for 6 or 7 years now, I've had trouble, and maybe I used to get a few new lesions, but really, all that happens is there's 1 or 2 spots that over and over again, flare up with an abscess. Maybe it's right before my cycle every month, or maybe it's, a half dozen times a year, and it flares up in an abscess. I'm miserable for that week. It drains, it calms down, but I know it's coming back. And I've been on, antibiotics over time. Nothing seems to really fix it, but nothing new ever comes. And so that's a patient where, long-term commitments to medications, sticking somebody on medication forever probably feels like overkill, or like it's not the ideal solution. And I'll give you an example. I do have like a photo of an area of just calm HS coming up on the next slide. I don't think it'll be too intense. The next slide will be a surgical photo, just of a surgical wound, and then the next one after that is wound healing. So if anybody does not want to see that, you maybe kind of have screen off for a moment, and I'll tell you when I'm kind of done looking at those kind of photos. But this is a patient where, every month, solitary area in the groin. And I see patients, this is like, not a super common story, but it is one that I see repeated from time to time, where they say, look, I'm actually really good other than this one spot. And so what I see here when I look is there's a little bit of scar present. This is where the drainage usually comes from, is this little opening right here. And it's very calm at this moment. But by feeling it, I can kind of feel that it's firm, kind of coming up into the crease here. And the patient can tell me, yeah, this is where it comes when it gets big. It's right there along the crease of the leg. And so again, I'm going to switch over the surgical photo. But this is where, instead of throwing one medicine after the other, doing what's called an unroofing procedure here, where this is where that bit of scar kind of was at the edge of that opening. And I use a little probe just to kind of feel under the skin and just feel where that pocket stopped and started, and removed that bit of overlying skin here. And so that's obviously not a fun thing to go through, but, she hurt, there's going to be pain with this, for that first 3 to 5 days, probably, that's kind of slows somebody down a fair bit. 2 weeks later, that wound is, half the size of where it started from, and kind of filling in. And so, that experience of, pain gets worse, having a bandage, it kind of slows you down for weeks. That's in a lot of ways similar to just a really bad HS flare, where sure, it's like, not an easy thing to go through, but I can do this and create a wound like this. And then, a couple of months later, and really this wound was probably healed within about 4 weeks or so all the way. The scar is kind of already starting to mature some, but now I've gotten rid of that pocket so that it shouldn't be able to flare up over and over again. And instead of her needing medicine, for months and years, I'm able to sort of, get this patient a lot better with a focused procedure. And had she had a lot of new spots, I would have been very hesitant to kind of approach it in this way. Because I worried we'd have cut this out and something else would have popped up and we would have just chased it forever. And if that had been a preference, that'd have been okay. But this is a scenario where minimizing medicines, focusing more on a surgery makes sense. All right, so I'm a couple cases in. Again, this is like an intense picture of HS. I don't think I've got any surgical photos coming up though. But let me pause and look at the chat box real quick here. And so let's see. All right, so there's a Q&A feature, and I think I saw it on the Q&A. I'm going to check the Q&A in a second too. But during the past 6 months, there's been some confusion. The EHSF said that HS is classified as a chronic inflammatory skin disease, and we have others saying it's an autoinflammatory disease. And the last one, Dr. Kirby said it was an autoimmune disease. And so, what is your opinion? So this is like a little bit of a tricky question because the vocabulary like overlaps in some ways. And I think, none of those things are terribly inaccurate, a chronic inflammatory disease is where the immune system is creating inflammation, chronically. Chronic means just over time. And so that's an accurate description. I think that's, maybe the best description out of those, where there's, again, chronic inflammation for a reason it's not terribly clear. Autoinflammatory, so auto means self and inflammatory means inflammation. So there's a unique group of syndromes that are kind of rare that are called autoinflammatory syndromes, where these, inflammatory pathways, there's usually a genetic thing that's happened that sort of has caused those pathways to be turned on all the time. And so they fit into this category we're called autoinflammatory conditions. And some patients with those conditions, they have a syndrome where HS could be part of it. And so, some people describe HS as being also autoinflammatory, that there's this inflammation that gets turned on from sort of self-triggers. And I think that's maybe not quite right, because in those genetic cases, again, the trigger is because there is this switch that's been flipped to on all the time when it should be able to regulate and turn itself on and off. With HS, there is something genetic that predisposes for some patients, but there's also, maybe some environmental trigger that's out there, whether it's, again, that normal bacteria that lives on our skin that sort of triggers the inflammation. Also, other things that play a role where it's not just a simple on-off, that you can, be somewhat predisposed, by certain genes, maybe, and not develop disease without the right triggers being present. And so it's maybe it's different than a classic autoinflammatory disease, but there is maybe some overlap. So I don't think it's the wrong thing to say that, or to sort of hypothesize that that's what's going on, at least for some patients. And then autoimmune, means that, again, autoimmune usually means there is an attack of the body against itself. So the body has developed an immune response attacking something on itself. So there's like a classic autoimmune disease. There are some blistering diseases of the skin where the body makes your body makes an antibody. So an antibody is one of many things used to fight infection. And that antibody actually attaches to something in the skin that causes it to sort of split apart. And so that's where, again, there's this very specific antibody that attacks self instead of something that's foreign. And that's not exactly what happens in HS. Again, inflammation is turned on in a way that's not regulated the right way, but it's not necessarily an attack against self, where it's programmed to attack, where your body is programmed to attack itself. So autoimmune, and chronic inflammatory, there's overlap in how people describe those things. I think, a chronic inflammatory condition is probably the best way to categorize it, kind of like things like, Crohn's and rheumatoid arthritis, where there's not necessarily a clear evidence of self-attack. That's a very long answer, maybe more confusing than it's worth, but hopefully paints the picture at least some. And then let's see, have we discussed diet recently? Let's save diet for the end to make sure we have time for some other things. So we have had some discussions about that in the past. And again, leaky gut or gut bacteria, kind of, let's wrap back around that one to the end too, because that's kind of a long discussion too, where there's not easy answers. In some places, and then kind of in one area mentioning that, sometimes over time, the roofs of the tunnels, sometimes those tunnels have multiple openings. Sometimes as the tunnels kind of calm down a lot, the skin overlying the surface kind of contracts and forms these sort of bands of scar tissue, or sort of rope-like scar tissue, where there's connections in multiple places, like a kind of like, again, where there's like a single rope, or where it's almost like a web sometimes with multiple connections, but there's clear space, kind of like larger spaces underneath those bands of scar. And that's an area where, doing a procedure where you sort of numb those, where those bands attach and sort of clip them away, you can remove that overlying sort of band, like a rope-like scar, without leaving huge wounds a lot of times, and sort of get rid of them if they're causing trouble by getting pulled and rubbed on. So certainly that's a unique form of sort of, tunneling or unroofing kind of, but there are ways to address that. And then what happens if you travel somewhere and can't get treatment for the chronic and rare disease when at the moderate to severe stage? So that's a challenge, finding, a clinician to partner with. And so, somebody else I think posted like the Hope for HS clinic finder. So there are some specialty clinics around. There is definitely big like deserts across, I say deserts, but like big areas where there are not clinicians who really specialize here really well. So it's a struggle in that case. Word of mouth can be very helpful sometimes, using things like Hope for HS or other social media to like figure out, I live in this area. Has anybody had luck finding, a physician close by that seems familiar and sort of willing to do things to help? Because there are certainly a lot out there that are not within those forums, or that are not within like those, kind of listings, but will sort of go to bat and work hard and try to come up with ways to help. And so, yeah, I mean, it's either, either being stuck traveling a bit further, or again, kind of having to do some detective work to try and find some good partnerships. And there are some places to start. Hudson County, New Jersey area. So, yeah, I would use the clinic finder. I think I'm blanking on it, the town that it's in. Amit Garg, that's G-A-R-G, is in, I believe, in New Jersey, kind of near New York. New York City, has a couple of people like Steve Cohen is there. And so this is getting like, again, we're getting into some very specifics here. But yeah, using that website too would be a good place to start. Let's see. And so then here's large areas removed and taking antibiotics. So I'm going to get through treatment algorithm a bit more in these next. So I'm going to pause again on Q&A, but I'm going to come back to. I know there's a long list there, but I do want to make sure we kind of power through here. But I will try not to leave anybody hanging. So, and this is another scenario which maybe feels familiar to some people, where it's like, I've already done a lot of other stuff. I've got very severe disease right now. It's flaring like crazy. I've already been on Humira. What's the next step at this point? And so in general, again, step one in a situation like this is figuring out a way to calm it down, right? It's going to be hard to fix all of this overnight. This patient's on a medication called infliximab, or a lot of people know it by the name Remicade. But this is a patient that has, very large abscesses, right? There's lots of drainage present here. There's a lot of scarring that's present already. And so this is going to be a situation where, trying to do surgery here when the tissue is very inflamed and it's going to have trouble healing, it's going to run into a lot of problems. And so the first step is, how do we calm it down, right? I want this patient to have less pain, less drainage quickly, be able to use that arm right now. That, getting that arm down is probably just painful to even think about because of the pressure it puts on those big abscesses. And so the goal is to cool it off. And so, sometimes antibiotics do that if you're sort of, kind of find the right mix. But this patient is probably going to be hard to fix completely with just antibiotics in the long run. And so this is where we're going to start escalating to other things. This is where the biologics tend to come in as a way to sort of calm it down and try to keep it calm over a longer period of time. And so you can tell here, those big abscesses are deflated. And there are still some areas where there's maybe a little bit of activity and drainage and scarring present. But this patient's going to be much more functional and be able to do the things that she needs to do to take care of herself and her job and her family, while we sort of think about how do we get things even better in the long run. So that's step one, is put out the fire. And then, after that, once we have things calm down, again, oh, sorry, it's clicking through faster than I wanted it to here. So this is sort of beforehand on both armpits. So, larger abscesses, a lot of drainage, calming it down, and then eventually getting to some procedures to try to help get things the best they can be. And so this is a point where, no bandages are necessary. There's no pain that's here. These scars are flatter. And again, this is, again, not perfect because of course scar is present, but, much better than where things started from, even for very extensive disease to start with. So, that doesn't mean the story's over and we just sort of stop everything at this point, but it means we sort of push things really far the right direction. And now we have a much better place to try to maintain it from. And so this was something where, probably the Remicade was around for, 3 or 4 months. We pushed forward with this patient wanted multiple stages of surgery where we sort of cut out and sort of stitched each time. So it took probably two rounds of surgery each time to sort of try to aim for closed wounds each time. Sometimes you can just do one at a time and that would have worked out well, but it would have been very hard to stitch it closed. And so these procedures were done over the course of probably 6 months or so. So, within, 10 to 12 months of starting, we've got areas in the underarms kind of fixed. There's still other areas in the body that we're going to have to address at some point, but we've had good momentum in the right direction. We just have to figure out how to keep that up and sort of match what the patient wants at this point of how fast to do things and how much to do. This is another example here where, again, it's hard sometimes to do everything with just medicine, right? Like this patient, had I shown you her before this patient was on Humira, before that, it would have been almost impossible to sit. This is kind of at the top of the gluteal cleft, like the crack of the butt. And so, she had multiple areas here that were sort of, draining a lot of pus. She was having to sort of change bandages multiple times a day to start with, and having a lot of pain. And once on Humira, there's less pain. There's not any active drainage you can see, but she'll tell you at the end of the day, she wears a pad and there's a couple spots of drainage probably in the back of it that she has. So she has to feel more comfortable wearing something. But it's going to be very hard to completely eliminate this with just medicine. And so part of the reason for that, I think, the next slide is not surgical. There is one coming up, but this is what this patient's disease would look like under the microscope. Is that, I know if you've never seen a slide, a microscopic slide of skin, when we remove samples, the pathologist checks and kind of looks to see what's there, and this is what they'd be looking at. Is that up here, this sort of thin purple stripe is the very outside of the skin, so that's the epidermis. Where if you look at the skin, that's what you're looking at. Most of the skin is this thick pink area here, kind of from here to here. That's what's called the dermis. That's like the thick leathery part of the skin. And these are tiny hair follicles up here on the surface. And so this is from the patient I just showed you, where they're, again, small follicles on the surface, and very, very deep beyond that is this big structure here, which should not be here. This is what that tunnel looks like. And I'm going to come in a bit closer to it here. But that tunnel looks very much like that skin on the surface looked like with that purple stripe. So these tunnels over time, not always, but over time, if they're around long enough, can get basically lined by sort of a skin-like lining, which, just like the skin, will replace itself over time. And so as much as I can try to calm things down, and I know if you're not familiar with these slides, this maybe won't make a ton of sense, but if you look at all these purple cells here, all these little purple dots, these are inflammatory cells that are coming in here and creating inflammation. There's actually not too many of them right now compared to what there would have been before. It would have just been a big sheet of purple, and you wouldn't have seen a whole lot of pink in the background if there was a big abscess there. But they're still there to some extent. I've got them way calmer than they would have been otherwise. But this is not inflammation, right? This is like skin replenishing itself, and so I can fix the inflammation with medicines. I can't make this completely kind of be erased most of the time. Though eventually the body might take care of it, but it may not for years, and so that's why things get so stubborn. And then I have a surgery slide coming up next. And so again, if you don't want to see it, please look the other way. And so what this patient surgery is going to look like is, this is, this little area here is what where one of those drainage points was. And the other one was probably right around here. And so normally when you cut skin, it looks like this, where there's some like fine bleeding here and there. It kind of has this reddish look to it. If you look kind of where it dove under the skin right here, this skin here is pale, but matches her background skin. And if this was a dark skin patient, there'd be dark skin that would kind of be lining the sort of inside of this tunnel that would match the background skin. And so there's no bleeding from this surface here. It's almost like somebody put a skin graft here, a year ago, and it took and sort of created this new space under the skin. And so again, that's why it gets so stubborn. Hopefully I'm not, and I don't want to push somebody's limits of what we're looking at, but I'm trying to illustrate that, this is why these things get so stubborn sometimes, is that it's more than just inflammation that develops over time. It is this physical change that often has to be addressed. And so obviously not a fun thing to do here, but this was a way to, I think I maybe have I didn't have her surgical scar here, but that's a way to, again, eliminate that pocket and try to get things better. And so if you're going to think about surgery as part of a treatment plan, so what should you expect, right? I think you can probably hear all different things, and people in this chat room have had all different experiences probably. And certainly it is not perfect every time, especially if things are unstable before you go into surgery. You're developing new lesions all the time. It's progressing. If you just start cutting things out and new stuff keeps coming, that can be extremely frustrating. And so the goal is typically to help calm things down, stabilize it, and then make the surgery count if you're going to do it. And so, when we've gone back and asked, some of our patients, what their experience was like, the blue here is basically like, did the surgery meet your expectations in these different ways? Like, would you recommend it? Would you do it again if you had the choice? And the large majority of patients here, right? So like more than 80% for each of these things, so that they're glad they did it, they would do it again. And the maybe category takes us up to like, 85, 90% for most of these. I am sure, there are some of these patients where, despite best efforts, like maybe things did not meet expectations, and that's frustrating all around. And so certainly there are going to be times where it doesn't work, but the large majority of the time, and patients are glad that they've done it and sort of, again, would want to do it again with the same outcome. And I don't have a medicine that probably works that well, right? Like even with things like Humira, people talk about 50% response rates. And there are risks that go along with medicines too. And so if I can do a procedure that, is this likely to help things, that makes me feel pretty good about doing it for other people. And just trying to make sure we get the best outcome we can. Now, what does the recovery look like afterwards? So I would never say that, again, it's a fun thing to have to do it. Asking the question of how do you rate that pain in your first week compared to an HS flare? Purple means that it wasn't any different at all. And anything to the right of that means that the pain was not as bad as a bad HS flare is. So most patients, and I think this is, something that some surgeons also understand, they've dealt with sort of painful, wounds on the skin from their HS and drainage and having to do wound care and bandaging. A lot of you guys are bandaging experts. Having a surgical wound is different in some ways, but there's a lot of crossover where, I think if you've coped with your HS for a long time, you can cope with getting through a surgical procedure and having a wound that will heal instead of being stuck with a non-healing wound. So, certainly some patients have more pain with their procedure. That's something where, being able to manage that afterwards is really important too. But it is something where, it is, if you've survived your HS as long as you have, most of the time, the surgeries feel survivable and like they've gotten, they've led to good benefit. And what's the average length of recovery look like? So this also varies a lot. I mean, I have some patients who are back at work the next day or back at school the next day for a smaller procedure, especially if they do something that's not terribly physically demanding. On average, patients reported needing about 5 days off to sort of recover before they felt like they could handle those things. Days to returning to normal activities, meaning, beyond work, like things like, exercising, sort of getting back to what their normal lifestyle would look like, maybe took about like a little less than 2 weeks on average. Again, some patients longer, some shorter, and that depends a lot on size and location of a procedure. And then days to complete healing on average is about a little less than 5 weeks. So certainly it can be longer sometimes. It's very unusual to have a wound that doesn't heal for 6 months. That means probably there's a lot of inflammation in the background disease and control, but usually it's going to be over the course of, 3.5 to 5 weeks is pretty typical for most wounds. I'm talking way longer than I should here, but I don't think I've got too much longer to go. And so again, surgery doesn't have to be a one size fits all thing either. And I think that's where people get into a trap kind of where they feel like, I saw a surgeon, they said I need a wide excision and that's the only thing that I feel comfortable doing. So it's, huge surgery or no surgery. And so that sounds very scary. And I think it can be. A lot of patients are nervous about an operating room and sort of, potentially being in a hospital overnight. And there are others that hate the idea of what I do most of the time, which is local anesthesia, where I'm just, I can give things to help people relax a bit ahead of time, but I can't put somebody to sleep in my clinic. But then we just inject numbing medicine around the area to get it numb. And because we do that a lot, we sort of, try to make it as easy as we can. I would never say that's, again, an easy or a fun thing to get through either, but it sort of saves the sort of, extra issues or risks of going to an operating room, having general anesthesia. And then lets patients kind of go right home afterwards with some pain medicine as opposed to sort of, again, being in a hospital setting. For other patients, that feels like, again, not the right fit, and they're much better off being served by a general or plastic surgeon with general anesthesia. And I think it's a lot about patients sort of driving their experience and sort of trying to find which feels like the better fit to them. Even with general anesthesia, talking with a surgeon about, look, to me, it'd be really hard for me to feel everything all at one time. I'd feel a lot more comfortable doing it in steps, right? So breaking, if the armpit is widely involved, breaking it into 2 or 3 steps, as opposed to just trying to do one big procedure, because that way maybe instead of needing, a week and a half or a couple weeks off from work, you can take a few days, manage a much smaller wound, and then sort of get back to action pretty quickly each time, as opposed to having to step away for longer. So I think depending on how much support you have at home, if you need it for a bigger procedure, doing a really big procedure or multiple areas at once will feel like the good fit because you get a lot over with at once. But if it's going to be hard to do that, it's better to make small stepwise progress than no progress at all if you feel like you're stuck without it. So trying to talk through those options is really helpful. I'll do a quick word on pregnancy because all these scenarios so far can arise certainly within pregnancy too. And that doesn't mean there are no options. A lot of patients get told, look, after you're pregnant, we can treat things, but there's nothing I feel comfortable doing, until that's over. And some patients would prefer that. If they're pregnant, they say, I'm not going to tolerate any risk at all. To me, I'll just sort of bear it as much as I have to and just kind of get through it. But there are things to do. And there is some evidence that letting things run out of control during pregnancy for things like Crohn's disease can have a negative impact on again, sort of things like earlier deliveries and stuff like that. So an uncontrolled chronic inflammatory condition can also take a toll and have risks that are the same or worse than a medication probably can. As far as options go, there are lots of antibiotics that are okay in pregnancy. There's pregnancy related infections that happen where antibiotics get used. And so there's a pretty good sense of which ones are sort of safer in pregnancy at this point and which ones aren't. Things like biologics are probably also mostly very safe in pregnancy, just based on looking back at patients who have been exposed and seeing that hasn't led to increased risk typically over time. So I'm usually, as always a discussion, but I'm usually not hesitant to use most of the things like the Humiras and Remicades during a pregnancy. Lasers are probably perfectly safe too, other than they cause a little bit of discomfort, but there's no sort of radiation or internal changes that happen from a laser. It's just a bright flash of light that heats up the follicles on the surface of the skin. So I typically think of that as being just fine. And even for procedures, general anesthesia, most surgeons are going to be hesitant about exposures during a pregnancy. But local anesthesia, injecting lidocaine with epinephrine is typically fine. And most, anytime I've asked an OB about it ahead of time, they've always been okay with it. So there's a way to sort of make some procedures happen if need even. There's a pretty intense photo of a patient with sort of a variation of HS that may be intense to look at. So if you don't want to see sort of wounds related to the condition, again, take a pause for a second here on this next slide. But this is there are times where, HS can just be like so far out of control, even with sort of early medication management that it's a struggle. And that's where you really have to think through things. So this is a patient that had been on Humira already. It wasn't controlling things. She'd been on Remicade and it was kind of so-so. We tried to switch some other things too, but she just kind of kept getting worse and worse throughout, right? And so this is atypical. She's got classic HS like under the arms and the groin area also. But she also gets these chronic ulcers on her legs and sort of other parts of the body that in some ways kind of mimic and can go along with hidradenitis sometimes. So, but I'm just illustrating the idea that even with like really hard pushing sometimes in the beginning, it takes a while to find the right mix of treatments. And so what do we do if again, Humira is not working, and I know antibiotics aren't going to do the job for this patient. It's going to be maybe partially helpful in the beginning, but something else has to happen. So, once the Humira hasn't worked, that's where everything else is off label, right? So, there's nothing else approved, and that will likely change in the next couple of years because there's lots of things in trials right now. But Remicade is probably the next, or infliximab is the next most common thing I use. That's an infusion medicine, meaning that you have to go somewhere and get an IV placed and get it that way. Then you take the IV out and you walk back out. The reason for that is just the amount of medicine you can't fit in a pen. If it could be done that way, if somebody could inject, 5 pens at home every time, but it typically just has to be mixed into a bag of IV fluid and given that way instead. But it's not as often. It's typically every 4 to 8 weeks, depending on what the patient needs. So it's not as often, but it's just a matter of setting time aside to be able to get it. The other things that you may hear some about, and if you look into like, either, papers that are published on sort of different ways to treat things, those are things, and because Remicade gets used a lot, like a lot of insurance will approve it now, or if your doctor appeals it for you, they'll often approve. There's often a way to get it. Whereas some of these others are trickier and they take insurance fights where it takes a lot of arguing back and forth with insurance a lot of times. So there's other things that are in the same class as Humira and Remicade, like one is called golimumab or Symphony, and the other is called certolizumab or Cimzia. So sometimes people use those things and can have some success even when these others don't work. When TNF inhibitors can't be used, probably the next most successful class, and maybe they'll ultimately end up being better than the TNF inhibitors even, is a medicine like Cosentyx, which is an IL-17 antagonist. That one's in clinical trials right now. It's approved for psoriasis already. Sometimes we can fight our way to getting it for a patient, but it can be a dead end sometimes and very frustrating if we spend weeks doing that and then there's still no medication on hand. Similar to this are medications like Taltz and a couple other medications that are in trials that are also IL-17 inhibitors, but figuring out the best dose to use for these things is tricky because they're not approved, that all those trials aren't complete yet. So, usually it's going to be somebody who's kind of familiar with HS that feels comfortable trying to sort of, figure out the ideal dose for these sorts of things. There's other medications like cyclosporin is a very old immunosuppressive medicine that sometimes can be helpful if it's needed to kind of rescue things, at least temporarily. There are things like JAK inhibitors in clinical trials for HS that are approved for other things that we sometimes, steal and use for HS. And then for the hardest to control patients, we often combine these things together, which there are no trials to help guide doing that sort of thing that tell us everything that I would like to know about sort of safety of adding things together. But there are times where benefit outweighs risk, right? Just like we avoid medications for risk sometimes, I am terribly fearful for a patient like I just showed you. What happens if we don't treat and we don't get more aggressive to try to control things, because that disease at that level, makes life unlivable in a lot of ways. And so it's a balancing risk and benefit of both medication versus risk of untreated disease, and everybody getting on the same page with that. So there's some creativity that ends up being required. And again, this is the last slide, and I think I've kind of driven this home point already, but there's not a single best path for everyone. And even each of these scenarios I showed you, a patient is going to help me decide what the best way to approach, their condition is. There's not one path forward even in each of those scenarios. Medication, kind of, again, sharing that decision making, on the patient end. I think if you're all here, that means you're seeking, what are different ways I could treat my disease. And that's a way you can be involved in helping make those decisions, is getting more good information. Oftentimes it takes, a mix of both medications and procedures over time for the best outcome. And so it's not, a single where we can do everything all at one time. And then, HS is stubborn, and like, I am, not as frustrated as all of you are having to put up with it, but it frustrates me to know, like, all the time, that I want things to do better as quickly as they possibly can be. But it takes troubleshooting sometimes, and there are ups and downs over time that occur, and we have to keep addressing it over time. And so, as frustrating as that is, and as easy as it can, I can understand if somebody says, "Look, I just need a break from medicines. I'm out of here for a while," like before, and then they, and maybe it takes them a while to come back in again. But if we stick with it, we keep trying it and sort of troubleshooting, most of the time we can make improvement. So it takes some sticking with it sometimes. But again, there's usually a good path forward. And so I want to get to the end there. Let me backtrack and sort of go back through some of the questions. Or Melanie or Angela, I don't know if either of you had anything in particular. I talked longer than I probably should have. Part of that was answering questions, but anything that you wanted to be able to say real quick before I sort of switch over to straightforward, like just kind of catching up on the chats and Q&As.
I think it sounds good to go do the questions.
Okay. All right. I've been only looking at the chat. I'm going to go to the Q&A box now, and then I'll go back to the chat in a minute. Let's see. And so again, there's a question here about diet and leaky, and also about leaky gut. And so I'll answer those things. So the idea of diet and leaky gut is that, well, leaky gut's a little different. That's the idea, is that you can get some bacteria or other things that sort of other things that are ingested that sort of leak through the gut wall, and then stimulate the immune system that way, kind of from the inside out. And then that leads to sort of more inflammation on the skin or in other areas too. And so leaky gut is a concept that comes up across lots of different chronic inflammatory conditions. And so, it's really tough to know like how much of a role that plays. Like, again, many patients feel like there are dietary triggers. The thing that come up the most are things like dairy, sugars, and sort of, some people say like white flour also. And so it's really hard to restrict all of those things. So I'm always hesitant to say really strongly that, that has to be the first step, because that's a quality of life question too, right? I think medicines affect quality of life negatively sometimes. So do lifestyle modifications if they feel very restrictive. And so I think dairy probably gets caught out the most. And so if people are able to, restrict that and doesn't feel like a big burden, then sure, that'd be an easy thing to start with. Reducing sugars, like sugary beverages and sort of other high sugar foods, is a good thing from an overall health standpoint, and maybe is also helpful. It gets harder and harder as you do things like paleo diets that are super restrictive. And I feel like, not being able to stick to a diet that's impossible, people end up blaming themselves sometimes and saying they just don't have, the willpower to sort of stick with the thing that would have fixed them. But that does not fix everybody. And it is a really hard thing to do. So that's why, again, I say I have sort of mixed feelings to some extent about those things. And so, again, I don't know that I can give you a perfect answer on diet. I think if that's feasible for you to do it, by all means. If that means less medicine for you and better control over time, I'm on board like 100%. But I don't overpromise, because I see lots of patients that do those things and they still need medicine on top of that, or they need surgery on top of that. So that's one other thing we add to the mix. All right, next question was, if you're Hurley 3 tunnels and scars, can you still do hair removal? And sure you can, especially if there are new lesions that are popping up, within those Hurley 3 areas or outside those Hurley 3 areas. And so it can certainly be something useful to add on, but I wouldn't expect it to, again, completely melt away like all the deeper tunnels. And so I'm getting off, I'm like losing my train of thought a little bit on that one. But yes, so it can be done, but it may just have a limit to how much better it gets somebody. It doesn't hurt to throw in the mix. Again, I think there was one here about traveling somewhere that somebody that doesn't know how to treat it. So, and that's a matter of, again, some word of mouth, looking through, forums and social media groups, I think, to get some good word of mouth on who might be helpful. Or again, things like that Hope for HS list can also be a good lead sometimes. Is another name for HS, Pyoderma significa fistulans. That is, it has probably been published under that name once or twice. That would be a very unusual way to hear it described, but that is probably the same thing. There's been other names over time, like Bernoulli's disease. Somebody once has described it it's been described a few times on the buttocks as fox den disease, saying the tunnels are like the den of a fox tunneling around. And then also acne inversa. So it has gone by different names, but that's, you probably found one of the rarest. Next question is, do I have to have tunnels removed if I get better, or can I just leave them alone? Will it affect me later if not addressed? So if there are times where medication does so well that there is very little pain, there is no more drainage anymore. And sometimes those tunnels over time can sort of change into being mostly scar, or maybe there's some texture to those scars, but over a long period of time, they can fade enough that they're not causing a problem. And if you say, look, my life is good, my HS is so much better than it was, it's really not affecting me negatively, then I would not talk somebody at that point into doing surgery, right? Surgery has a negative effect on quality of life, like all the other things we talked about. If life is good, I do not have to I would not talk somebody into sort of rocking the boat by doing procedures that don't feel necessary. But that's a question, that's again, something I'm gonna talk with a patient about typically, and sort of make sure we feel like we're on the same page with that of, are there things that bother you about what's there? Does it feel worth it to you to do surgery, knowing this is what surgery entails? And if the answer is no, then yeah, you don't have to have that done. That doesn't mean that worse things are going to happen. I guess there might be instances where, there's a little bit of drainage still, the disease is kind of smoldering and still a little bit active. And I would, in that case, just say, if we do the surgery, that'll get you to the point that, you can get completely away from having drainage at the end of the day, potentially, right? If there's a couple spots of drainage, or, I might be more successful getting you off of your medications, because if we stop them now, those areas might start flaring back up again. So if your goal is to be off medicine, then maybe the surgery gets you to that. But if you decide, look, I'm good maintaining on medicine, let's keep it there, then I would say keep in that direction. Okay, my derm doctor says smoking marijuana can make my HS worse, but I was told by a 5-year medical student from plastic and general surgery that tobacco is worse than marijuana. And so that's, there is evidence that, smoking does not cause HS by itself, probably, right? Like if I look at patients who have come into our clinic under the age of 18 of years, and they've already got HS, and I've had, we have probably 100 or so like that now. None of them were smokers, actually, or maybe there were a handful that just didn't tell me, but most of the time disease started before smoking, probably. There maybe are some that develop it later in life, and maybe smoking is somewhat of a trigger, but that's not the case for most. Smoking is linked to sort of more resistance to treatment, maybe more progression over time. And so it may be that it is harder to get as good a control with tobacco smoking. Marijuana is a big question mark. I think it is probably less harmful than tobacco or nicotine containing products, because there's receptors for nicotine that are maybe involved with inflammation very specifically, whereas those same receptors probably are not going to be triggered by marijuana. So I can't tell you that it's that it's definitely a problem. Again, it's important to be safe in how you use things like marijuana, but I couldn't tell you that they're definitely linked to making HS worse. Okay, I have lymphedema in my lower legs and HS in the groin area. Is there a relationship? So it's possible, if there was extensive lymphedema in the groin from prior scarring from very extensive HS, it's possible that from lymphatic scarring that predisposed towards lymphedema. But I would say not typically. That'd be sort of an exceptional circumstance. Most of the time, if there's extensive edema in the lower legs, that'd be related to other things, whether it's, there could be underlying heart disease. Sometimes people have sort of, issues where for whatever reason there was blockages or weakening of the blood vessels that help to drain the blood from the legs. And so I would probably look for other reasons first before just blaming the HS. So seeing either a vascular surgeon or a vein specialist of some kind would probably make sense or sort of at least talking to your primary doc about imaging of the legs, but it's not impossible. And some patients just have edema for unclear reasons. There are even just genetically, some people are predisposed to developing leg edema over time. And it may not be related to either to any of those things, but it'd be worth thinking about other things first. All right, if marijuana is helping flares and pain, is it beneficial to continue medicating naturally rather than starting Humira? I mean, if marijuana has like its own implications in different places as far as like, again, legal ramifications, and maybe there are some health risks that go along with it, but, marijuana is probably safer in some ways than things like Humiras and stuff like that. And so if that clearly works for you, I cannot tell you that's the wrong thing to do. And it's always risk benefit. And if that has had low risk for you individually and gives you a lot of benefit, I would not say that like, that the things that I would do are going to definitely be better than that. Maybe we could find an alternative, if you're one to not have to use marijuana. But again, there's no studies on it, and I couldn't say that it's not helpful for anybody. And so the next question here is something I can definitely understand. Like, I don't want to be on Humira forever, and with another autoimmune condition, Humira can make things worse. And so that's very true. Like Humira, medicines like that, these anti-inflammatory drugs, it's a commitment, right? It can feel like you're stuck on something once you start it. And so again, that's the balance, right? Is like, finding something where, sure, there can be like some risk of side effects, but finding a medication that you as an individual can put up with very well, that doesn't cause problems, but that helps your HS, right? And is that trade-off worth it, right? If the HS is having a big negative impact on your life, chances are that a medication to control things better on balance means a much better quality of life for you, even if you have to be on a medication, right? Like I said, I fear what HS does when it's untreated, much more than I fear a lot of these medicines. And so for you, a TNF inhibitor is probably not going to be the right thing if you've got a clear diagnosis of lupus. But that's where I would try to look into again, things like IL-17 inhibitors, like I mentioned, like secukinumab is in stage 3 clinical trials and is looking very likely, very much like it's going to get approved within the next year or two. But looking at different classes of medicines that would maybe help reduce that inflammation. And so, again, if you say, and for that, or maybe antibiotics or things like a laser over time, like certainly you can try other things first other than committing straight to a medication. But I think you have to constantly reevaluate, which of these things feels like the scarier of the two things. Like, is it worth trying to find a medicine that's well tolerated and I can get comfortable committing to it over a longer period of time? Is that better than the HS, or is the HS tolerable enough that to me it still is not worth, medicines, and I should just try to find other things like, laser or surgery instead. So it's hard for me to tell you the right balance for you, but I would just try to, again, weigh those two things side by side, the untreated HS versus, a quest for a medicine that's well tolerated, that helps you enough that you say it feels worth it. And then next question is, does brain fog have a connection to HS? I cannot tell you any scientific study that talks, about, necessarily directly connecting brain fog to HS. I mean, certainly brain fog, or certainly HS is linked to, consequences on mental health in general. And some of those things, like, if there's anxiety, depression, things like that, can lead to sort of a feeling of brain fog. But it may just be that chronic inflammation in general, there's some evidence that things like the TNF, like those inflammatory signals, affect neural pathways to some extent. And maybe it's more than just, I'm putting up with HS and that makes me feel depressed. It's actually like has a direct connection to like how your brain works sometimes, and all this inflammation is elevated, and that maybe affects how people think to some extent sometimes. So I can't tell you again, there's any papers that would help back that up, but if you notice that, hey, my HS is out of control and my thinking becomes foggier, I could believe that if it gets better, does that improve? I think there's potential for that. Next one is, can laser hair removal cause you to break out, and should you be on an antibiotic? So typically not. I would say most patients don't notice a breakout immediately afterwards, but maybe there's been a few patients, very infrequently, that say like, that week afterwards was worse. And again, it could be that something else made it break out. And I'm going to come back to the chat questions after this. There's one more here, and then I'm going to come back to the chat questions. And so maybe every now and then somebody is sensitive and it makes them break out. Most of the time, I don't make it so somebody needs to be on an antibiotic when they get their laser done, like trying to avoid a breakout. But if somebody notices that after the first treatment or two, then I might do that, or we do something else to make sure that's not the case. But that'd be unusual. And then next one is, can inflammation cause nodules to be cut out? So I'm not 100% sure, or to be cut off. So, I'm not sure exactly what that's asking. Like, I mean, sometimes if there's enough inflammation, if there's areas of old scarring, like sometimes the overlying tissue can sort of be, almost sort of like auto amputate itself in a way where a portion of skin, sort of comes away. Maybe that's what you're getting at. Usually for like an individual nodule, if it's new, I would not say like it's worth doing surgery right away to cut it out, unless it's been there long enough that it looks like it's going to become recurrent. Okay, but feel free to put that one again as a clarification. Another one here, tunnel is shrunk to a 1/2 inch nodule. So it's possible, and sometimes tunnels, as that overlying scar retracts, occasionally become more focal. It's possible that, one of those tunnels can resolve itself over time in that way. Well, let me switch over to chat questions here because there's a whole bunch building up there. I'm doing as rapid fire as I can here to try to get to everybody. Okay. Some of these I've gone through already. Sorry, I'm scrolling. Make my chat box bigger so I can see more. All right, so what are your treatment approaches to constantly draining perianal HS without Crohn's with early stage 2 and 3 disease? So in some ways, like similar for that body location as for others, where the first goal is, calm the inflammation down. And so with, especially with perianal disease, if there's a lot of tunneling, can be very, very stubborn in that location where, you reduce the pain, you reduce the drainage, but there can sometimes be limits to that, where, sometimes it can be really good. Other times, it feels like we're not making enough of a dent. And that's where procedures can be helpful also. That's a little bit of a tougher area to do. And I think some surgeons have very different approaches to that. Sometimes the problem is with perianal disease, especially, the surgeons go much bigger than they need to, or sort of deeper than they need to. Or they want to do things like put an ostomy on, like to where like the gut is hooked up to the abdominal wall to sort of drain into a bag, as opposed to worrying about soiling the wound from having a bowel movement, which I think is typically not necessary. I think most of the time the wounds heal just fine, even if they do get slightly soiled, kind of gently cleaning, the wound still, it's very unusual for them to get infected still. So again, it's going to be, trying with medications, to get better control. And once it feels like things are stable and the inflammation is somewhat calmed down, hopefully, planning on a surgical procedure. And if things like, again, the Humiras and the Remicades don't work, I think I mentioned IV ertapenem on one slide, where if nothing else is working well enough, things like IV ertapenem can be a rescue therapy. That's very frustrating to use because it's not frustrating, but time intensive and sort of tough to use, but it's a once a day home IV antibiotic infusion where a home health nurse teaches you how to do it, and you have to have a special IV. You typically do it for 6 to 12 weeks. And then sometimes, if things have been very stubborn, like doing that for 3 or 4 weeks, getting a surgery done once things are calmed down, healing up while the IV antibiotic is still going, that sometimes helps set the right stage if nothing else has worked well, but you still often need something on the other side of that, right? So you still usually need something that's more long-term to control things, and you can't just stop it after 12 weeks or things act back up again. So it's just a matter of sort of escalating, considering procedures for the extensive tunneling if medicines alone aren't doing well enough. Let's see. Red light therapy, is it real or fake? So red light therapy is something where there are lots of over-the-counter like red light devices for things like acne. In clinics, sometimes we use red light along with a chemical that we put on beforehand. It especially sensitizes people to that light. That's called photodynamic therapy. That's a bit more intense. That the one that we do in clinic has had very mixed results. Of people have tried to study it, where some patients feel like they're better. A lot of patients don't get better with it, and it's because HS has its ups and downs. That it's something that most people aren't terribly excited about doing or don't feel like it helps all that much. Home red light therapy, again, like there's been some evidence that maybe it's somewhat helpful for acne. And I don't totally discount the potential for light to be helpful, and I say that because we use like a different type of light, like UV light, kind of like similar to what's in a tanning bed, but we use a very specific and safer wavelength in the clinic. And there are medical lights that can be done for home use even. But I have, not just a few patients, a good number of patients that tell me that, yeah, if I get sun, like if I go and I sun and get, sun under my arms, or if I use things like a tanning bed, that helps. And I think that makes sense because UV light can be anti-inflammatory for a lot of conditions. Like it is something that's approved and done often for things like psoriasis. And for HS, it's never really been studied, but I think there's something to it for HS where probably UV light is helpful. Now, red light is different. There's a different mechanism behind red light where maybe it's helpful for acne, and it's possible it would be helpful in HS, but nobody's studied it well enough for me to tell you really much certainty around that. So I have trouble telling you for sure that that it's definitely helpful, but it would be an extremely low risk thing to do. Probably not super high cost. Like I think, the drawbacks are very, 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 very few. And if there's maybe some benefit to it and you feel like I've tried lots of other things, to me, it's worth trying it, then by all means, like I wouldn't tell you it's the wrong thing or that there's zero chance of it helping, but I wouldn't overpromise either. There's a chance it helps, but it may just not be enough is the issue sometimes. All right, next Facebook question. What is it about inflammation that makes someone tired? I know that with 100% certainty, if I start napping or getting, or if I start napping or getting tired, they'll flare up within 2 or 3 days. That's a good question. Like, what is it exactly about inflammation that makes people tired? I mean, like your body has to work hard to create inflammation. So that maybe part of it is that it takes a lot of metabolic effort on the term of your body to sort of, get all these sort of white blood cells going and getting them to the right place, creating an inflammatory response. That is something that the body has to work kind of hard to do. And so there's probably some energy expended, on the process itself. The other part of it is that like when your body, say your body had HS is not an infection, but, it sort of, when you respond to it or when HS goes, it sort of mimics how our body responds to infection. And part of how our body responds to infection is that, some people with HS also get like low-grade fevers along with their flare-ups, and they sort of feel crummy and achy. And so, all those inflammatory signals going on one time can make people feel bad on more than just the skin. And so, that sort of sense of fatigue can definitely go along with HS. Like some patients feel like, I didn't realize how fatigued I was or that my joints were aching when I was flaring until I got on a medicine that actually calmed things down, and it becomes clear after the fact. So hopefully that helps to some extent to answer a little bit of that. All right, so a couple of these questions in the chat now are a repeat. If you have mild HS, can low dose doxy work, or does it have to be 100 milligrams or more? Let's see. So that's hard to know too. I mean, like we use lower dose doxycycline and minocycline for things like acne and rosacea, and lower doses have been found to be just as helpful for those conditions. When I've tried to use like 20 milligram doses, I think some still get some benefit, but it's maybe not, for some, not quite as good as the higher dose is. So it's hard to know. I think if the higher doses like have caused some side effects and some issues, and you feel like it's helpful, it can be worth trying lower doses like 50 milligrams twice a day, or even the 20 milligram versions a couple of times a day. And sometimes that gets around side effects and is easier to put up with. But if it clearly works better at 100 for you, I don't have much hesitation about continuing that over a very long period of time. It's like when you're on it, things are good. When you're off, things are bad. Long-term use is very reasonable in my mind. Like there are lots of uses for chronic long-term antibiotics, whether it's patients who are chronically immunosuppressed for things like transplants, or patients who have syndrome where their immune system doesn't work right and they need to be on everyday antibiotic for their entire life. So safety-wise, I think there are times where benefit outweighs risk if it makes the HS better. Okay, let's see. Can the tunneling from HS cause nerve damage? It's unusual. HS, as much as like it can feel like it gets very deep sometimes. Like we have those big nerves that kind of are in our armpit to give control to how our arm works, right? So, and I've never seen a patient where it's tunneled so deeply that it's affected those nerves or gotten into those really big blood vessels that cause like dangerous bleeding, or people can bleed out in minutes if they were to get trauma, like if they had an injury to that area that sort of traumatized those areas, or will cause their arm to be paralyzed. And so, that sort of nerve damage would be I've never even heard of that happening. I would never say never, but like super unusual. There are some smaller nerves that run closer to the surface of the skin that maybe just give sensation to a small area of the skin. So there is a nerve that's under the arm that more often gets affected in surgery if the surgery is deep enough that it's kind of down into the fat. But occasionally a patient with HS gets deep involvement where they feel like they get shooting pains kind of like on the sort of upper inner part of their arm here or up onto their shoulder up here. And that's where that's called the intercostobrachial nerve. So that if that nerve gets inflammation around it, there will be shooting pain like that sometimes. And in those cases, if a surgery gets done, it's hard to completely leave that nerve alone if it's just kind of tangled up within the HS. But for most patients, that's not the case. Most of the time, it's unusual to have true nerve damage. Have I seen success with metformin is the next question. So sometimes, metformin, like some of the other things, can be a little hit or miss where, I think some patients feel like I think it takes a couple of months or a few months to really do its thing, but some patients do feel like things are much more stable after a while of being on it, but it's not usually like a night and day difference where you start it and 5 days later, it's like everything feels suddenly all the way better. But I think there are some patients where it definitely feels like their disease is more stable over time, like they're not developing as many new lesions as more time passes. So I think there are times where it's reasonable. Now, if I like the worst patient pictures I showed you, like extensive, tunneling and scarring, like I don't have much, optimism that metformin by itself is going to fix a patient like that, right? It would be something I would add to the mix maybe to see if it would give some additional benefit, but by itself, it's not a fix for a patient like that. It's been more in those earlier stage patients where I'd expect it to hopefully do the most by itself. All right, any products I recommend for dealing with scarring, like topicals and such. So scarring is tricky for any condition. Scarring, there are things like Mederma creams, and some of the ingredients and stuff like Mederma have been shown to maybe improve scar appearance over time. So those are low risk things that are okay to do. People use those, what are called like little micro needle rollers for things like acne scars or even like try to help with fine wrinkles some. So you can get a micro needle roller device very inexpensively from a place like Amazon or a lot of drugstores and try to use that sort of once a day or sort of a few times a week across scars. Again, it's not an overnight thing, but it may be that helps to sort of remodel scarring to some extent as time passes. And it's relatively painless. It's these little micro needle rollers that don't feel super intense, but just create a little bit of trauma across the surface of the skin. And then sometimes I use things like lasers that, just like we do for things like, acne scars or sort of burn scars to kind of help sort of blend and sort of soften the scar some. I'll use that for some patients too over time. The trouble is if the HS is active and you start doing that, it's just new scars develop. And so it doesn't feel like it's worth going through something as intense as a laser like that. But those are potential ways to try to help to some extent. And there are some creams, if you have scars that are darker than the surrounding skin, where that's what draws your eye the most is the color mismatch. There are some like skin fading creams, like most over-the-counter hydroquinone products don't exist anymore, but you can get things that have what's called kojic acid that will help, doesn't burn or anything like that, but there are certain fading creams that have that ingredient. That will fade the dark skin a little bit over time, or there are prescriptions that contain multiple ingredients sometimes, like hydroquinone and kojic acid that can help to fade that darkened skin also. Also slow moving, but can help a little bit. Could a different TNF blocker like Tepeza for thyroid eye disease be helpful for HS? Because I have both issues. I'm not completely sure what to, I'm gonna use my phone to look up what Tepeza is the trade name for. That's teprotumumab. I think this must be something that's kind of injected into the eye itself. And so it's probably not approved for other things that are where you get enough absorption like into your whole body for it. So I have trouble saying that like I've ever heard of that being used for HS. If it's a TNF inhibitor, like it might be helpful if you had a dose big enough to affect like all over the body, but not something I would have any experience with and could talk too strongly to. Let's see, I have lost weight and have excess skin. Will the HS affect the loose skin folds, or would surgery have to be done? So it's possible. It's one of those things that's really hard to predict. Like sometimes skin on skin friction triggers things, and so that can sometimes be the case. And when that happens, sometimes removal of some of that excess skin can be helpful to reduce that friction. But convincing a surgeon to like figure out how to get that covered by insurance or how to get it done is a challenge sometimes. But I have definitely had patients where because that's felt like a trigger, or because they have, even though they've lost weight, they have disease left behind in those areas, surgery still ends up being helpful to improve it over time. So yeah, certainly that becomes a question with weight loss, is whether a surgery like that could be done. Let's see. Do I suggest bleach baths? Like, bleach baths are maybe somewhat helpful like other antiseptics. Again, they've not been studied in an organized enough way that I could tell you for sure that they're helpful. Again, low risk of harm for things like atopic dermatitis for little kids that get staph infections. It's helpful. That's why people kind of started using them the most. But then sometimes people end up using it in HS also. So it's possible there's some benefit. I think there's low risk of harm. Again, for those who haven't used a bleach bath before, it's typically like half a cup of water and a half tub of water, or a cup of water and a full or a cup of water in a full tub. And so you don't you don't want to overdo it, because bleach can be very harsh on the skin. When you dilute it that much, it's safe. But again, like basically like half a cup and half a tub, or a full cup and a full tub. It would be the most I would do. A connection between PCOS and HS, that has been like very well described, where the risk of PCOS is much higher with HS for whatever reason. I don't have a perfect explanation for that either, but there's a clear link there, where patients with HS, are more likely than patients without HS to have PCOS. And that's polycystic ovarian syndrome. And that's where the ovaries develop cysts that prevent eggs from being released every month. And so over time, a lot of patients stop having menstrual cycles. There are ways to sort of, trigger menstrual cycles to happen with certain medications to try to address it. But yeah, for whatever reason, it is more common with HS. Let's see. So there's no about, with chronic tunnels, as the sort of roofs of those tunnels have sort of, formed that rope-like scar and sort of broken in some areas. There's areas where there's a lack of sensation, where some of the new skin has grown over. And that can happen too, where, if some of the nerves of the skin are sort of damaged from chronic inflammation, they can be less sensation over time in some of those areas. And sometimes that sensation returns, just like after surgery. It takes, weeks or a few months. Other times there can be long lasting numbness. And that can be hard to predict, but that can certainly happen sometimes, usually with kind of more extensive disease. Let's see, can HS lumps also occur in the scrotum? Scrotum can be involved by HS. That is a place that could potentially be affected. And then also, can HS cause a fever? It can sometimes. So some patients will say when they flare, they'll get, more often like a low grade fever, like 100, 100.2. But occasionally a patient has a fever even higher than that. But that's usually with, again, like very extensive and severe disease, more than with kind of more limited disease. Next, there's another question about diet here. I try to eat totally healthy, but I don't understand why I randomly still get inflammation. My HS was under control for a long while. I thought maybe because I've been cooking in the microwave, it could be related to that. So I highly doubt it. Microwaves work just by, microwaves, when they interact with water, they cause the water molecules to heat up. So it's not like radiation or where it changes the food in some way. And so I don't think it has to do with food prep. And again, I think with diet, like sometimes dietary changes help. I think even patients that have, as perfectly healthy of a diet as possible, and they avoid any trigger they ever read about, again, some of those patients, like, they still have HS, right? So there's more to it than just diet. Like, diet may be a piece of the puzzle for some patients, but sometimes things like this, have a bit of a mind of their own and are going to behave, in a way that's hard to control with just diet. And what are things you can do early on to slow progression? So I think, again, early on, the more you sort of keep new lesions from coming, the sort of less likely there is to be scarring and tunneling. And so whatever it takes to sort of stop sort of new lesions developing, whether that's antibiotics or the hormonal therapies, are probably helpful. I think the hair removal lasers, because you're permanently reducing follicles as you do more treatments, that's less areas, like less hair follicles get inflamed over time. And so I do think that is something where if you do that early on, it maybe means less risk of disease progression over time, and maybe less medication need over time. So I think that's a nice thing to throw into the mix early. But the biggest thing is, again, just figuring out how to sort of reduce how many lesions pop up over time. Another question about scar tissue making movement painful, and that can be the case where if scars tighten, then they get pulled on as like an arm moves, or as the leg moves and stretches the groin. And so for that, again, like sometimes if it's more of those band-like scars, then removal of those scars can be helpful. There are things like different types of lasers that can soften and sort of help scars be less restrictive. Sometimes certain things like physical therapy that sort of, create constant, frequent stretching will allow the scars to remodel and get a bit stretchier over time. There's some ways to try to help with that over time. And then does hidradenitis show any geographic data? So there's really few studies from outside of North America and Europe. There are some trends that have shown that hotter places like the southern US tend to have higher either internet searches about HS or things like ED visits around HS. Those things are higher in the South compared to areas that are sort of higher latitudes. And so as you get to cooler climates, less humid climates, you maybe have less likely to have HS, but there's also differences in things like racial distribution and other background health characteristics that make that hard to interpret completely. I don't know of any studies other than a few from the Middle East that have looked at the experience of HS in Africa. So it's a huge question mark actually. We know that in general in the US, that Black people are more likely to be affected than white people are. But how that plays out in terms of the African population is completely unclear to me. And there's been very few done. There's a little bit in sort of the eastern part of Asia, South Asia, not a whole, there's a few studies out of there, but not many that help really understand things like how common it is. And I mentioned ED, and that may have been interpreted as erectile dysfunction. I'm in an emergency room. That the ED is the emergency department. So, looking at studies about patients who go into the emergency room. And then again, there's a question here, kind of recapping some of the first step treatment. So again, that depends on patient preferences a lot. So I think sometimes antibiotics are helpful either as sort of a constant thing or as an episodic thing. Flare-ups are kind of infrequent. Just having an antibiotic on hand as opposed to all the time antibiotics is probably a better solution. A lot of the things are more everyday things, whether it's the birth control pills or spironolactones or topical things. And then things like the laser, I think a hair removal type of laser are very helpful early on. And then when those things aren't working well enough, that's where it's things like, the biologic type medicines, sort of mixing and adding these things together. And then again, thinking about surgical procedures too, if there's a lot of tunneling around. And so it's very different person to person, depending on what their disease looks like and what their preferences are. I think Angela and Melanie, I think this is going to be posted as a recording. Is that right?
Yes, we'll have a recording.
Okay, so yeah, so there should be hopefully a way to go back and view it after the fact to catch some of that also. You mentioned Vicks Vapor Rub. I think those things are probably somewhat soothing, and some patients feel like it helps if something needs a drain, it helps it come to a head faster. That can certainly be a useful thing to use at home that can be somewhat soothing at least, and maybe help something calm down faster. And then one more question here. One person told me that the following diseases are connected to HS: diabetes, alcoholism, drug addiction, Crohn's, diabetes, depression. Are these really connected to HS? Are the above correct? And are there other things? So yeah, there are a lot of things where if you look at big databases of sort of things like insurance claims and things like that, and you look at, do patients with HS, are they more likely to have an insurance claim or or somebody to visit put in a code for depression for a patient with HS compared to people without HS, that have been recorded in the system? Then yeah, there are clear links where things like depression and anxiety are more common. Diabetes is also the case. About 20% of patients that have HS have diabetes, and probably another 20% or so are pre-diabetic. Alcoholism and drug addiction, those are very weak connections in my mind. That was those things that came up at very, very low numbers in the general population, and still at very, very low numbers in the HS population, but there was a slight difference. And again, I think there's issues where, HS patients are more likely to sort of, be in places like emergency rooms or have more doctor's visits where some of those things just get picked up on more often because they're in the health system more. And so they're more likely to have it recorded. And so, those things can certainly happen. And I worry about things like, alcohol and drugs, but I can't say that I see a super strong link there. And the vast majority of patients, if I give them pain medicine, they're not, seeking pain medications from tons of other doctors or sort of seeming like they're overusing them. It usually seems very appropriate. So where there may be slight links there, I think they're relatively weak. Crohn's is certainly linked, about if you have HS, you're about 3 times more likely to have Crohn's disease. you have Crohn's, you're about 6 times more likely to have HS. And so chronic inflammatory conditions can definitely run together sometimes. That being said, that's like a long, scary list. And there are other things that are sort of also listed as potential comorbidities, whether it's things like even thyroid disease, which doesn't make much sense to me, maybe a slight link to things like lymphoma. Again, those are very infrequent things, and they're still infrequent. Somebody here mentioned suicide rate in HS relative to the general population. There is like slightly higher rates of suicide also reported within the HS population. Again, most patients, like for most of these things, these are still like relatively uncommon or not that much more common than they are in the general population, because depression and diabetes are already very common in the general population. So those risks are there. And I think that's like all the more reason that we're controlling HS well, and that over time, I often, if we have good control and we have a chance to discuss some of these other things, we try to sort of like make sure that there's a primary care doc in the picture, or somebody that can help kind of manage some of these other comorbidities. And again, it just shows sometimes the harm of not treating a condition, right? If we let inflammation go crazy, that's probably what sort of relates to some of these things developing, like even things like heart disease with chronic inflammatory conditions, that there's higher risk. If we can control that inflammation well with medication and reduce some of those risks, potentially it feels very worth it. Hormonal and environmental triggers, that can, that probably is the case sometimes, like hormones, before a menstrual cycle or with pregnancy, or again, around the time of puberty, there are different hormonal triggers that can probably play a role. And that's where some of those hormonal things become useful sometimes. Is it worth visiting a teaching college for treatment if there's not a local dermatologist that's very familiar? That can be helpful. In particular, again, some teaching environments may not always be better, but usually they're going to have dealt with more patients that have not found help at the local level. And so they're going to be willing to try other or different things, or have a decent way to point you in the right direction at least. So that would be like a reasonable step up, is to try like an academic or teaching hospital where they're more used to managing more complicated things. And then in particular, if there's somebody, like I would look at their website, their faculty listing to see, does anybody have hidradenitis listed as a particular interest of something they are sort of used to treating more often? Or again, using things like the HS Foundation website to look for, or sort of, again, a local, like a social media group, to try to identify either a local doc or somebody that's been helpful, in the area at least. And one question about, if somebody's also got Crohn's, is it worth adjusting the Humira dose if they're still flaring? Yes, sometimes we do go above beyond typical dosing, where we'll double the dose. That, or switching to other things like Remicade I mentioned earlier, can also be helpful. So yeah, if you're not doing well enough, if even one of those two, either the HS or the Crohn's is not doing well enough, that's a reason to sort of change a dose around, change medications to try to sort of handle both at the same time. All right, I think I am probably caught up on questions at the moment. I know we're past time at this point, so we should probably kind of wind it down. I don't know, Angela or Melanie, any last things you wanted to make sure to address now, that because we only have 10 minutes in case there's any other stuff you want to make sure to mention as part of the meeting. I want to make sure to give you time.
Okay, Melanie just has a few slides to wrap up. So
Okay.
at any time when you're ready, she can do that.
Okay, well, I'll do that because, like I said, time's getting close here to the end, and I think we still have most folks on. So again, thanks everybody for for letting me come on and chat. Hopefully the information was helpful, and it helps to point some people in the right direction and give you an idea of sort of what things might be useful and sort of what a treatment course might look like. And so like I said, there's I think Hope for HS does a great job disseminating the info. You'll be able to watch again later, and then with the right feedback, we can sometimes build future sessions around what your interests are too. So thanks again. I'll kind of hand back over to Melanie now, and I'll stop my screen share here. Oh, I think actually it's already off. Okay, perfect.
Thank you so much, Dr. Syed. We'll just have a few quick slides to run through at the end. I know that, all of us have friends that are fitness enthusiasts, and you may have been envious of them for being able to participate in events and get really cool swag, and your HS may have prevented you from being able to do those things too. Well, we have a solution for you. Sign up for the Walk, Run, and Rest for HS awareness event. You can complete the event anytime between now and December 7th. The link to register is here on the slide, or you can also get to the link from the Hope for HS website. And then proceeds from this do go towards Hope for HS activities, which include bringing you webinars like this one. Okay. And then also for those of you that may have had.
I'll say it's a very nice soft shirt, nice purple color.
Yes, and Dr. Syed's one of our poster folks for the swag. Also, if you have had COVID, there are researchers that would be interested in learning about your experiences. This survey is open to HS patients that have had COVID-19 and their caregivers or medical providers. Okay, and then last but not least, we want to say a huge thank you to everyone that was able to join us today, as well as to Dr. Syed for presenting such informative material. Please join us for future meetings. You can see the schedule on our website at hopeforhs.org/online. And from there, you can also sign up for our mailing list to learn about upcoming meetings and webinars as well. Angela, any other last words before we end the webinar?
Nope, I think that sounds good. Thanks, everybody. Have a good day, evening, afternoon. Okay, goodbye.
Yep. Thanks, Angel and Melanie. See you next time.